Good afternoon, everybody, and welcome back to the second in our series of keynote conversations. I'm R.D. Sahl from Boston University's College of Communication. As social entrepreneur in residence at NEHI, the Network for Excellence in Healthcare Innovation, Dr. Molly Coye thinks about connected health now and down the road. Her job is to look at the forest and the trees. And she brings a lot of experience to this task. Formerly the Chief Innovation Officer at the UCLA Institute for Innovation in Health, and one-time State Health Director in both California and New Jersey. Ladies and gentlemen, I'd like you to meet Dr. Molly Coye. Molly, thank you for being here.
Thank you.
So nice to have you. I'd like to start with kind of a definition at the very beginning. What's your mission as a social entrepreneur in healthcare?
All right. Well, I think everybody in the audience will resonate well with the idea that there are far more good innovations out there that actually would be terrific for patients and their health that are not really adopted as quickly as they ought to be, that we have a real problem in that regard. So entrepreneurs in residence usually exist in private equity firms, and they're looking for really good market opportunities, new innovations to build into companies. I'm a social entrepreneur, so I work with NEHI, which is a nonprofit organization, to identify those really terrific innovations that really ought to be adopted more rapidly than they are and figure out what are the ways to help them move faster.
So by extension, the innovation is moving more quickly than either our ability or willingness to accept it?
Yes, that's it in a nutshell.
What do we do about it?
Well, there are 3 or 4 different answers. The first thing, though, is we continue to work to align the market incentives. Because even if you're in a public hospital system, you still orient yourself to what the payment system is. And most of our payment, probably about 70% of the payment in the country, is still payment for doing more services of the current kind. Fee for service, variations on that. And the push towards value health is very good, but it's way too slow for what we need to really be a platform for the best innovations. So aligning the reimbursement is very important. And then the second challenge, I hate to say it because I'm a physician myself, but the second challenge is doctors and hospitals. Doctors and hospitals are used to working in one way. Their whole culture, their training, is to work the way they are currently providing care. And asking them to make pretty fundamental change, disruptive change, is not easy, even if the systems align technically in terms of reimbursement.
It potentially changes the doctor-patient relationship, doesn't it?
Yeah. I mean, just think, I've recently gone to groups of physicians and said, I would recommend that you adopt one of the modalities where you can go online, email, or there are actually, and again, like Joe Kvidar did this morning, I'll tell you if I have a financial relationship with anything I mention. But if you go on, for example, at UCLA, we experimented with Zipnosis, which is a completely online acute care episodic disease diagnosis and treatment system. And it worked very, very well. The doctors were even enthusiastic about it, but the system was very concerned because what would this mean for everybody who normally would come sit in a doctor's office and pay for a lab test that they might not need, when instead they can have it so conveniently at home.
Another stakeholder in this is insurance companies.
And again, full confession, if you've read my bio, you'll see that for the last decade I've been on the board of Aetna, which is a big health insurance company. And I'm very excited about it and proud of it because we're one of the most advanced in adopting innovations of this type. But it's still very hard. If you're a health insurance company and you take a given market, whether it's Boston or Des Moines or wherever, you might have 10% of the doctors in your network or 20%. So that doctor can't practice differently for your patients or your members than for the rest of her patients. So it's complicated, as they said this morning.
You have a rich full day every day on this. Sticking with this reimbursement issue for a moment, Is the Affordable Care Act, our health care reform effort, a friend or a foe in reaching this alignment you're talking about?
Definitely a friend. First of all, the most important thing is it has covered an enormous number of people who didn't have access to health insurance. And that's fundamental. Now we're talking about how we use those resources by health plans or delivery systems to make sure people are getting the best care they can. And so I think that alone would justify its existence. But also more recently, everybody acknowledges that the first 4 years was focused more on coverage, but now they're really shifting to the emphasis on value-based payment and payment for bundles of care as well as global budgets. So I think it's having a very positive effect. I'm just impatient.
Here in Massachusetts, we've done a good job on the access side of this, but we still haven't managed to corral costs. Does the concept or the whole field of connected health help in that regard? Is it the answer to bending the cost curve?
It's not the total answer. I would say it's necessary but not sufficient. In other words, many of the solutions that actually bring down cost also improve access and in many cases standardize quality and improve it. So it's a huge part of the answer. You couldn't do it without the technology, but it's not enough. You need a lot of other change in leadership and the missions and purpose of the provider organizations.
On the part of patients, are they accepting of this new technology or are they a little wary of it?
Well, it all depends on whose aunt you talk to. But basically, they are the driver, not the barrier. I mean, we're seeing huge adoption in middle ages and even elderly populations of many of the technology-enabled solutions. So the assumption, and we're also seeing this in lower socioeconomic status. We're seeing it across ethnic and language lines. So the consumers are the drivers generically. They're the ones, I think that the biggest two drivers for advance in care are the technology and the developers of new services who understand what the technology can do, and the other are the consumers who want, this is now a very well-known idea, but basically you're banking, you're dating, everything else is done online, so where's healthcare?
Yep. So the bottom-up effort here is really important to this. None of us like to be dictated to.
Yeah. No, it's very, very important, and I'll give the example of another, and I'm drawing on examples from UCLA, where I was the Chief Innovation Officer until June. We heard about Doctor on Demand, and Doctor on Demand allows any patient anywhere to talk with a physician, but not necessarily their physician, on their mobile device and pay for it with their credit card, et cetera. And so all of our physicians were, oh my gosh, what is this going to do to continuity of care and everything else? Well, we started conversations with the company. It turned out that you could make an arrangement so that that patient, if they're a patient of your system and you participate, they can automatically get access to either their doctor or a doctor in your medical group. So the fact that they were smart about the strategy was pushing our medical group to participate in something that they would not have been likely to do.
So performance is proof when you can make it happen.
Right, and when the consumers are adopting it, when they're getting big uptake, that's what makes the doctors and the hospitals sit up, is, oh my gosh, people want this.
If we develop a truly connected health system, what impact does that have on access in states where they haven't gotten as far along that path as we have here in Massachusetts?
I think that we're going to see huge battles in the states. If you think about the Texas State Medical Board, which recently came out with very regressive regulations about allowing consumers and doctors to use some of these platforms, we'll see some states where for a while there's a real hold, but they'll see what's happening in other states. And consumers, somebody in Dallas, their mom in Colorado is getting access to a kind of care that isn't allowed in Texas, and there will be pressure and it will change. But it's a big difference state by state across the country.
In the sessions I've attended this morning, there's been a lot of demonstration, emphasis, and talk about new technology that is primarily monitoring technology, reporting data. We spent some time with Vinod Khosla this morning.
Right.
He said the next step in this is turning this data into a predictive tool.
I think there's an intermediate step which is very valuable on the way to the predictive capability, and that is to have a closed loop feedback to the patient, to their family, with guidance. Now, you know, this morning Joe had Sam on his mobile device of how that would be 5 years from now.
My voice, by the way.
Oh, was it? I didn't recognize it. Well, I better change what I was going to
No,
say,
no, no,
because
no, 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 no,
I was
no.
going to say I would never have Sam doing my guidance. It was far too authoritarian for me. But I think that we really need to have this development of the feedback to the consumer, because right now there's a lot of guidance and support and information that can be provided without even knowing what the prediction would be.
Right, I've got my Fitbit in my pocket and it's recording everything I'm doing, but what do I do with it, I guess is the question.
Well, I don't know about you guys out here, but I used the Up Band, which had a great tracking of sleep. And that really changed the way I try and approach sleep. So I think there's feedback even in those things that's very good, even in the consumer wellness products.
The development and adoption of connected health technology, I think, assumes some level of technical infrastructure. What are the possibilities, the promise, and perhaps the peril of connected health in developing countries? Have you worked on that?
Yes, I have. I've worked a lot in developing countries, and I've spent time recently in India and a number of other places, China, looking at what they're developing. And the first thing I would say is, because the needs are so great, the pace of innovation is much higher than in the United States. We might have more companies, but they have more adoption. They're actually using the solutions. For example, Google India has partnered now with 14 states in India that covers 750 million people for an emergency response system that is mobile device and telephone mediated, that is, you can go on and look at it as GVK EMRI, and it's really doing tremendous job, and it is incorporating analytics and predictive analytics as well.
So there's a technology leap going on here. They're
Way
dropping
ahead
out
of us.
lots of the intermediate pieces and going right to the goal.
Right. Exactly.
And that would seem to have consequences for access to health care in countries where there may not be as developed a health care infrastructure as we have here.
Well, and actually, it has big meaning for us, not just for our rural areas, but in many of our urban areas. I mean, Los Angeles, it can be only 3 miles to a hospital. It can take you 45 minutes in rush hour. So it's much better to be able to deal with a patient in their home than have them have to go to an emergency room. So there are a lot of opportunities in the US to take what's developed in developing countries, transform them and transform these innovations and use them here.
Would you have any advice for innovators who are working on new things in this field to make sure that not only the technology works and is good and reliable, but that people are open to it? How do you make the pitch?
Yeah. Well, I think probably one of the most important things is to be very selective about where you're getting your advice from. Very often an innovator who doesn't have a big background in healthcare will pair up with a physician or a couple of physicians who are very excited about a particular product idea of what it could do. But they may not be very aware of the real market forces that would lead that product to get used or not get used. So they can put a huge amount of effort into developing something that actually, when it arrives, if it's going to be the hospital that has to make the decision about a purchasing, or a private physician's office, or a health plan, and just not hit the mark, not be realistic. And I think that's one of the most common problems. So I would say, if you have the opportunity to work either with an innovator or an accelerator, or many health systems now have innovation centers or innovation officers whose work in part is to work with the innovators and help them understand what the real need, or how to, often it's just shifting slightly the focus of the development efforts to make it something that'll really work.
Lots of smart people working on lots of smart technology. Some of them will succeed, some of them will fail. What will make the difference?
Well, are we allowed to count serendipity? A lot of this, believe it or not, is you may have a great idea and a great product, and you've even got really good advice, but then do you get connected up with good funders? Do you get connected with a health system or a health plan that has an appetite for trying something different? It's sad, but you do have really good innovations that just don't get those opportunities.
That would suggest that strategic alliances involving hospitals, insurers, doctors, and innovators,
right,
and of course patients, might be a good idea.
Well, and I think that you sailed right into that, because in a sense that's what NEHI, the Network for Excellence in Health Innovation, is doing, is it's brought together all those partners, and they're particularly focused at looking at what can both government and the private sector do to drive the pace of innovation.
What about government investment in this? Should there be more?
I don't really think there should be a lot of government investment in specific companies, because government's a big lumbering elephant. I mean, I can say that because I was Commissioner of Health in New Jersey and Director of Health for the state of California, and you know, we are not a good business partner. I think having government put money into the training of people, into universities, so that you get more people with education and have the skills to do this, and have competitions and RFPs and all kinds of things that reward people who come out with good innovations is great, but I would not think that we should make government another investor.
As a former health director in two important states, New Jersey and California, is there a public health dimension to connected health that goes beyond the relationship between you, your care team, and your monitoring device?
That's a great question, and there is, and it's very important and really exciting, and a lot of the people, if you go to the M-Health conference each year, a lot of the people in M-Health, I wouldn't say a lot, but there's a big chunk of them that are working on open M-Health, and they're often working with communities for things like mapping food supply and food deserts in urban environments, mapping pollution. So when you have, they just, Propeller, I think they renamed the company, I'm not sure, but there's a asthma company that works very well for understanding when the triggers are for your asthma and tracking it and communicating with your health system. And that is made possible in part because there's very good tracking of the pollution levels in the community. So there's a lot that can be done by taking this into the community and broader factors like training for jobs, housing, even things like there's now been much more effective finding of lead poisoning. They can actually work backward in big data sense from the data on lead poisoning diagnoses and then send the public health authorities into neighborhoods that are near to the ones that had the problem. So
it's the use of big data to focus data on a patient population and then individual patients.
Right. But along the way, correct some of the context that causes the problems rather than just going directly to the individual patient.
So we have a sense from the sessions at this conference and from what you've been saying this afternoon about where we are now. Where would you like to see us in 10 years, 20 years?
Well, Joe did part of the job this morning in describing it, but more than that, I think the thing that is not talked about enough is that it really is I don't know what my grammar should be, it's the community service providers. If you think about social workers and community health workers, it's people in the community from the languages, from the cultures, who often have either no medical training or they were a medical assistant or something.
But they see medical problems every day.
The key to improving everything is the behavior change of the individual patients. Nothing in medical education helped us actually get anybody to be motivated to do something different. The community health worker or the social worker is much better at that. So what we need to be doing is working to a panel size where today a physician has, depending on the mix, they might have 1 to 2,500 patients that they care for in a year. We should have the physician caring for 10,000 patients and have a whole squad of the community health workers and the social service workers, et cetera, paired in teams with the health system. And we would see health of the population escalate much faster than what we're doing now.
Are medical schools doing enough now to prepare new doctors for what's coming?
I would say no. As a matter of fact, at UCLA, our medical students rose up and organized their own course because they felt that they needed it. And I think there's a lot of variation. You know, different schools have different new courses, but by and large, it's a kind of add-on, elective, if you feel like it kind of thing, rather than a central redefinition of how they're going to practice in the future.
What's on your agenda going forward? Got a project that we should watch and be tracking?
Well, I think one of the biggest ones is actually going to be here in Massachusetts, because the legislature and the Health Policy Commission are going to be working on helping providers and health plans and communities adopt innovations. And so I'm helping them a little bit, and I'm very excited about it. I think Massachusetts has been a leader for a long time, and we can see some good new things coming out of this.
And finally, Molly, what's the metric for you personally in this process? How do you know it's working? How do you know we're on the right path?
One metric is how many people are affected by something that makes their life better. When I was Commissioner of Health in California, we took 6 million people in the Medicaid program in California, and we took the women and children's part of that into managed care. We were one of the first states to do that. Before we did that, we said that having a Medicaid card was like having a hunting license to go out and try and find a doctor who would take care of you. And within 3 months, everybody in that set had a doctor that they had access to. So looking for that kind of flip of the switch. And I give the example again, there are a lot of people who don't have a primary care physician, don't have access. If we start providing them access on either a cell phone or a smartphone, depending on telephone or video, that's going to make life very different.
Don't you just love listening to smart people? Dr. Molly Coye, thank you so much.
Thank you.